Welcome back to the Deep Dive. Today we are diving into the controversy over statins.
Right. This is a big one.
It really is. I
Yes.
mean, this is arguably the most successful, most prescribed, and definitely one of the most profitable pills in pharmaceutical history.
Absolutely.
And yet, for all its success, and it does prevent heart attacks and strokes,
Yeah.
it's just been constantly embroiled in controversy.
From, these bitter academic blood feuds and public health scares about brain safety, all the way to the astronomical costs of the next generation alternatives we're seeing now.
It is truly the billion-dollar pill under fire.
And the stakes couldn't be higher for millions of people. I mean, our sources today are going to take us right into these high-stakes medical journal wars.
And then pull us out again.
Right, and pull us out into some really detailed financial modeling on what the true economic value of these drugs really is.
So our mission in this deep dive is to try and cut through some of that noise.
Mm-hmm.
What's the settled science? What specific risks are actually real versus, what's just fear?
In money.
And the money. Perhaps most importantly, what does the massive financial fallout of this whole cholesterol debate look like for, the average person, the insurance company, and the entire healthcare system?
Okay, so before we unpack all that conflict, we really need a shared baseline. We have to understand what these drugs are actually doing.
Right. Let's start simple.
For anyone joining us, we're going to use a simple analogy for how cholesterol moves around your body.
Okay, let's do it. Let's untack this with a mental image. I want you to think of cholesterol as these vital packages being delivered through your bloodstream.
Okay.
And these packages are carried by little structures called lipoproteins.
Which are basically delivery boats.
Exactly, they're delivery boats. And we really focus on two types of those boats.
Right, so first you've got the low-density lipoprotein, or LDL. This is the one that gets all the negative press.
This is what we'll call the bad guy boat.
The bad guy boat.
And why is it the bad guy? Well, because the LDL is responsible for driving around your body and just dropping off those sticky packages, the cholesterol, right onto the walls of your arteries.
And when too much of that happens, when there are too many packages being dropped off?
The artery walls start to harden. They start to narrow. That whole process is called atherosclerotic disease.
And that's the primary culprit, right? It's behind most heart attacks and strokes.
Mm-hmm. Then you have the second type.
High-density lipoprotein, HDL.
The good guy boat.
The hero of the story. It has a very different job. It patrols those same routes, but its whole mission is to clean up.
It picks up the excess cholesterol from the artery walls and ferries it back to the liver for disposal and processing.
So the more good guy boats you have, the better.
Okay, so if the problem is an excess of LDL, too many bad guy boats dropping off sticky packages, how does a statin fix that?
Well, this is what makes statins so brilliant. They attack the problem at the source.
So not in the arteries themselves.
No, they are drugs that work primarily by slowing down the production of those LDL bad guy boats right where they're made.
In the liver.
In the liver.
Yeah.
By restricting the supply of those delivery vehicles, you significantly reduce the amount of sticky plaque being deposited.
And that, in turn, reduces the risk of those major cardiovascular events.
Exactly. And that benefit, that proven link between lowering LDL and preventing heart attacks and strokes, is built on this massive foundation of data. It's largely undisputed today.
Especially for high-risk patients.
Absolutely.
And yet, the controversy just persists. Why?
Because the debate has completely shifted. It's moved from efficacy to safety and access. So now we're dealing with questions about, very specific side effects, who should be treated, and whether the massive costs of the new treatments are even sustainable.
So we have to start with those public disputes, the ones that really threaten to erode trust in the very data these drugs are built on.
The scientific fight club.
Here's where the high-stakes drama really began. I mean, we're talking about a public conflict between the editors-in-chief of two of the world's most prestigious medical journals.
The BMJ, the British Medical Journal, and The Lancet.
And this wasn't just, simple disagreement. This was a public breakdown of trust in the foundational data, and it dates all the way back to 2013.
So the whole dispute kicked off when the BMJ published 2 papers that year. And these papers, they contained a claim, and it was traced back to a single source that suggested statins cause noticeable side effects in just an alarming number of patients.
The number was about 20%.
20%.
Just think about that for a second,
Right.
20%. If you're prescribing statins to millions of people for primary prevention, so they haven't had a heart attack yet, but they're trying to prevent one, a 1 in 5 chance of a debilitating side effect, that completely flips the risk-benefit analysis. especially for those lower risk people.
Oh, that figure is catastrophic for public health messaging, just catastrophic.
So what happened?
Well, the medical community, they immediately revolted. Shortly after it was published, a group of really prominent researchers, including authors who were involved in these massive landmark statin trials.
People like Professor Rory Collins' group, the Cholesterol Treatment Trialists Collaboration.
Exactly. They argued, and they argued fiercely, that this 20% rate was vastly, wildly overstated. So they alerted the BMJ that the claim was fundamentally wrong, and they demanded a full retraction of the papers.
That is a huge amount of pressure to put on a journal editor.
Yeah.
I mean, when the very researchers responsible for the core body of evidence are demanding a retraction, that's serious.
It is.
So what was the BMJ's response?
Well, the journal did concede that the specific 20% figure was incorrect, so they corrected the articles to remove it. But they stopped short of full retraction.
Why?
The editor-in-chief, Fiona Godley, she commissioned an independent panel to review the whole situation using what's known as the COPE criteria.
COPE is the Committee on Publication Ethics.
Right. It sets the standards. So the argument really boiled down to this. Was the error so fundamental that the entire paper was now unreliable? Or was it a serious mistake that could be fixed with a strong correction?
And what did the panel say?
The COPE panel concluded in August 2014 that the papers did not meet the criteria for retraction.
So what does that mean?
Well, a retraction is typically reserved for findings that are just so seriously flawed, either because of misconduct or an honest error, that you just can't rely on them at all.
Okay.
But if the primary conclusions of the papers were still considered valid, then correcting that specific data point was deemed enough. The BMJ defended its decision, saying it was upholding the standard of transparency and ethical review.
But the shadow of doubt lingered, right? The public sparring between the journals went on for years.
It did, and it highlighted this deep, almost emotional investment on both sides of the argument. On one side, you have the advocates who are worried that sensationalizing the risk will cause millions of people to stop taking a proven life-saving drug.
And on the other side, you have critics who are concerned that all this pharmaceutical-funded research is just minimizing real side effects that patients are experiencing.
And that emotional investment, it led to a really deep structural problem. It led to gaps in our knowledge and this desperate call for a genuinely independent data review.
So what were the gaps?
Well, critics pointed out some severe limitations in the existing statin trial data. For instance, there's a really pronounced lack of sufficient data on people older than 80 years old.
Which is a huge oversight. Age is the #1 predictor of cardiovascular risk.
It's a massive oversight. And that population, people aged 80 and over, it's growing rapidly.
So if we're advising millions of people in that age group to take a lifelong drug, we need solid evidence, not just, guessing based on a younger, healthier trial population.
Precisely. And what's more, there were complaints about the uncertainty of comparing adverse event data across different trials. Different studies look for different things. They use different definitions.
So it's hard to get a unified picture of rare side effects.
Yeah. It is. And critics also noted a lack of head-to-head comparisons of individual statins.
Right. Is Lipitor and Crestor, are they really interchangeable in terms of their risk profile? We needed better data to answer that. And I think the biggest issue that came out of this whole journal war was just the demand for transparency. Specifically, this critical need for the raw patient-level data.
The raw data.
I mean, if you have a bitter public dispute, the only way to resolve it is to hand the evidence over to an independent third party for review.
This is so crucial. The editor of the BMJ publicly stressed this need for an independent review of the individual patient-level data from the original statin trials.
Because sharing that granular data would allow independent researchers to settle the dispute once and for all.
It would. But even that process, it was tainted by conflict of interest concerns. The very group that ran many of the original trials, that cholesterol treatment trialist collaboration we mentioned,
Yes.
they announced that they were going to undertake a detailed review of adverse events using their own trial data.
Which was immediately met with skepticism, I'm guessing.
Oh, absolutely. Critics argued, and I think quite reasonably, that you can't be considered truly independent if your organization was funded to run many of those very same trials.
It's just a perception issue. When industry-funded trials are already under scrutiny for potentially downplaying harms, having the same group review their own data, it just fuels the fire.
It does. It creates a perception that the researchers are, as one source put it, inherently wedded to that idea.
It's a fundamental challenge of trust. We need definitive answers on risk. But if the source of the answer is perceived as biased, then the public health message just gets lost in the noise. And that sets a perfect stage for our next part, because if the risk isn't 20%, what is the real specific risk, especially the unexpected ones like cognitive decline?
We shift now from the historical academic fight to concrete biology, and we have to start with the 2012 mandate from the FDA.
This was a big deal.
It was a major regulatory action that required new warnings on all statin labels for potential adverse effects on cognitive performance, specifically memory loss and confusion.
And the fact that the FDA put a blanket warning on an entire class of drugs, a class used by millions, that's startling. But you mentioned that later deep dives into the data showed this class warning was just wildly inconsistent.
It was.
So why did the FDA apply it to all statins if the risk varies?
That's the core issue. Regulatory bodies, they often apply warnings broadly across a drug class unless there's just overwhelming evidence to distinguish between the individual molecules in that class.
And in this case, there was.
In the case of statins, the difference is fundamental. It's rooted in how the drug molecules dissolve.
Wait, let's look at that fundamental property, the solubility. So whether a drug dissolves better in fat or in water determines where it goes in the body.
And that is absolutely critical when we're talking about the brain.
Right.
Indeed. So we have to introduce the body's highly specialized security system, the blood-brain barrier, or BBB.
Think of it as a super strict gatekeeper.
Right. It's made of these tightly packed cells and fatty membranes that protect the brain from toxins, viruses, and a lot of drug molecules that are just circulating in the bloodstream.
So we have two types of statin molecules trying to interact with this fatty gatekeeper. First, you've got the lipophilic or fat-loving statins.
These are the sneaky ones.
The sneaky ones.
The fat-loving statins, primarily is atorvastatin, which you probably know as Lipitor, and simvastatin, or Zocor. They are highly effective because they readily dissolve in fat.
And because the blood-brain barrier is made mostly of fatty membranes.
These drugs are inherently sneaky. They can just bypass the security checkpoint entirely, diffusing passively and non-selectively right across that barrier and into the brain tissue.
Which sounds like a bit of a design flaw if the whole point of the barrier is to protect the brain.
It can be.
So once these fat-loving statins cross that barrier, what's the biological mechanism for potential harm?
The harm relates back to their primary function, which is inhibiting cholesterol production. Now, while the liver produces about 80% of the body's cholesterol, the brain synthesizes its own supply.
And it needs that supply.
Oh, it's absolutely vital for normal neuron function, for maintaining cell membrane integrity, creating those insulating myelin sheaths.
So if a fat-loving statin gets into the brain and starts shutting down cholesterol production there,
you run the risk of disrupting normal neural communication and integrity, and that is the suspected mechanism behind these reported cognitive issues.
Okay, now let's look at the second type, the hydrophilic or water-loving statins. These are the ones that respect the gatekeepers.
Exactly. These drugs, which include rosuvastatin, Crestor, and pravastatin, are far more targeted. Because they love water, they really struggle to cross the fatty membranes of the blood-brain barrier.
So they're designed to be what's called hepatoselective.
Liver-focused. They can't passively diffuse into non-liver tissues.
So how do they even get into the liver to do their job?
They rely on specific active transport systems. Think of them like designated delivery trucks, like the OATP1B1 transporter, that actively pump the drug from the bloodstream into the liver cells.
Which means they achieve much lower exposure in other tissues.
Dramatically lower exposure in non-hepatic tissues, including the brain. They stay focused on the liver, where they need to be, and they largely respect the blood-brain barrier.
That is such a critical distinction. So if the biology is that different, the real-world safety data has to reflect it, right?
It does.
So let's look at the massive public complaints box,
Mm-hmm.
the FDA Adverse Event Reporting System, or ADRs.
AURs is a really powerful tool for detecting a safety signal. Now, it doesn't prove cause and effect.
Right.
But if one drug has a disproportionately high number of reports for a specific symptom compared to other drugs, that's a huge red flag. And the analysis of ARS data for cognitive dysfunction was definitive in supporting this solubility theory.
So tell us what the analysis showed. What about the cognitive risks for the two major groups?
The analysis showed that the risk signal for cognitive dysfunction was significantly and disproportionately higher only for the highly lipophilic statins.
Atorvastatin and simvastatin, Lipitor and Zocor.
Exactly. When researchers calculated the proportional reporting ratios, which is basically how often a side effect is reported for a drug compared to control drugs, The ratios for cognitive dysfunction were alarmingly elevated for just those two specific molecules.
How high was that signal?
The signal for cognitive dysfunction was reported to be around 2.5 times higher for atorvastatin and over 2.2 times higher for simvastatin compared to controlled drugs.
And what were the symptoms?
The most frequently reported issues were cognitive disorder, amnesia, memory loss, and generalized memory impairment. This data really strongly suggests that the 2012 FDA warning should have been molecule-specific, not applied across the whole class.
And what about the water-loving ones, the counterparts?
The hydrophilic statins, rosuvastatin and pravastatin, they showed essentially no evidence that would suggest a heightened cognitive risk. Their proportional reporting ratios were negligible when you compare them to the control drugs.
This is crucial information for doctors then.
It is. If a patient reports memory issues on Lipitor or Zocor, the data strongly supports switching them to Crestor or Pravatrol rather than just stopping the therapy entirely.
That is a massive practical takeaway for anyone listening. If you have to take a statin and you're worried about memory issues, the specific molecule you take really, really matters.
It absolutely does. Now, let's just briefly touch on the other major side effect controversy, muscle symptoms, or myalgia. While the cognitive side effects are a function of solubility, muscle pain is. It's more complex, and it's often clouded by the power of suggestion.
Okay, so we know that severe muscle damage, a condition called rhabdomyolysis, is a known but incredibly rare side effect. But what about the more common, less severe muscle aches that so many patients report?
This is where the clinical trial data often clashes with patient experience, the big, randomized, double-blind trials. They consistently show that statin therapy has little, if any, effect on common, less severe muscle pain, unless it occurs alongside an elevation of muscle enzymes, which indicates actual muscle damage.
So, if the big trials don't show the pain, but patients are reporting it so frequently, what's going on?
It's the power of the nocebo effect.
The evil twin of the placebo effect.
Exactly. Patients are often told about the risk of muscle pain. It's on the label, their doctor mentions it, so they start monitoring every little ache and pain that they would normally just dismiss as, routine, aging, or exercise.
And because they expect the pain, they experience the pain, and they attribute it to the pill.
That's the theory. It's a fascinating and really difficult dynamic to manage in clinical practice.
So how do we know this isn't just, researchers minimizing a real effect?
Because we have some brilliant studies that show this in action. There were some crossover trials that enrolled patients who had previously reported intolerable muscle symptoms and insisted they were statin intolerant.
Okay.
These patients were then secretly given alternating periods of high-dose statins, low-dose statins, and a placebo.
And the results?
In many cases, these individuals reported the exact same level of muscle complaints, whether they were taking the active statin or the inert placebo pill.
Which strongly suggests that for a large percentage of those common aches, the pain is real, but the cause isn't the drug's pharmacology.
Right. This complexity-proven efficacy, a contentious public debate, and side effects that vary so drastically by drug type and psychological expectation, that's why settling the score has been so hard.
Let's move to part 3 and try to definitively answer the question. Is lowering LDL cholesterol the right thing to do?
To understand the persistent skepticism, we really have to address its historical roots. People often forget that so many now accepted medical practices were once intensely debated.
Like what?
Well, for decades, doctors debated whether it was even safe to treat hypertension. They feared that high blood pressure was some necessary compensatory mechanism the body needed.
It's incredible to think about that now.
Yeah.
And similarly, the early attempts to lower cholesterol were fraught with peril.
They were. And that helped fuel the skepticism that still kind of lingers today. You have to look at the clofibrate trial.
This was back in the late 1970s.
Right. Researchers were testing clofibrate, one of the early cholesterol-lowering drugs. And the drug did work, in a sense. It reduced the rate of non-fatal heart attacks, which was a clear success.
Wow.
But that study delivered a major psychological blow to the whole concept of cholesterol lowering because the group taking clofibrate experienced a slightly higher rate of all-cause mortality compared to the placebo group.
So people looked at that and concluded, okay, it prevents heart attacks, but I'm more likely to die overall.
Which must have been terrifying.
Of course.
And this fueled that persistent, though we now know incorrect, belief that actively lowering cholesterol could be dangerous, that maybe it impairs brain function or causes other non-vascular deaths like suicide or cancer.
And even though later analysis suggested Those excess deaths were likely just statistical noise or random chance.
The perception that tampering with cholesterol is risky has never completely left the public consciousness.
But the statin era changed everything. It provided just an overwhelming mountain of data. So what is the definitive proof that overrides all that historical skepticism?
The proof is in the consistency. It's in the proportionality that we see across hundreds of randomized controlled trials and meta-analyses. The proportional reduction in the rate of major vascular events, MVEs, is directly and linearly related to the degree of LDL reduction you achieve.
A linear relationship.
Yeah.
Which means it's reliable. So if you reduce the number of bad guy boats by X,
You get a predictable reduction in major events. Why? The reduction is about 20% per 1 million reduction in LDL cholesterol.
and that's consistent.
It is so consistent across different populations, different trials, different drugs, that it really moves beyond hypothesis and into established biological fact. It shows the mechanism of benefit is fundamentally tied to how much LDL cholesterol you can clear out.
And this overwhelming proof also allows us to definitively debunk the pleiotropy argument. This was the very popular theory years ago that statins didn't work just by lowering LDL, but they had some sort of magical non-cholesterol effect, like anti-inflammatory properties.
That theory was a strong driver of skepticism for a long, long time. And if pleiotropy was the primary mechanism, then other drugs that lower LDL through completely different pathways, they shouldn't offer that same proportional benefit.
But they do. The new drugs prove the mechanism.
Precisely. The introduction of ezetimibe, which blocks cholesterol absorption in the intestine, and then later the really powerful PCSK9 inhibitors, they provided the definitive answer.
Because they work in totally different ways.
Entirely distinct mechanisms from statins, yet their cardiovascular benefit is directly proportional to their ability to lower LDL, which strongly confirms that the primary benefit of this entire class of drugs is, and always has been, the reduction of LDL cholesterol.
So that closes the loop on efficacy. But if the data is that comprehensive, we can now address some of the common criticisms about who this applies to.
Yeah.
Does the science confirm it works for groups that were maybe excluded from early trials?
Yes, it does. Critics often claim statins weren't effective in women or the elderly because those early trials were so male-centric.
Right.
But subsequent subgroup analyses, based on robust data from trials that enrolled thousands of women and participants over 75, they confirm a couple of things.
Curse.
Efficacy in women and the elderly. The effects of statins are similar and beneficial in women and in people over the age of 75. That proportional risk reduction applies across these groups.
What about for people who haven't had a heart attack yet? Primary prevention.
The benefit is undeniably smaller than in secondary prevention. So, treating someone who's already had an event, but statins still provide a clear benefit in primary prevention for individuals identified as high risk.
So the criticism that they offer is zero benefit for prevention.
It's just not supported by the data.
Okay, so the scientific verdict is settled. Lowering LDL cholesterol works. But just to keep this conversation balanced, we have to reiterate the two small but very real harms that have been confirmed in these massive analyses.
Absolutely. The trials strongly refute claims of increased cancer or non-vascular mortality. Those historical fears are largely gone. But two concerns are small, but confirmed. First, that small excess of myopathy and rhabdomyolysis we discussed, it remains a rare possibility.
And the second confirmed harm is the most paradoxical one, the increase in new diabetes diagnoses.
Correct. The trials confirmed a 10% proportional increase in new diabetes diagnoses. And that is a hard number for patients to swallow. You're taking a drug to prevent heart disease, only to increase your risk of developing another major chronic illness.
It sounds like a terrible trade-off. Can we contextualize that 10% increase? Who is most at risk?
The analysis is very specific. The excess risk happens primarily among patients who are already predisposed to developing the condition.
So people with a high body mass index, prediabetes.
Exactly. Or slightly impaired fasting glucose already. The statin seems to just accelerate the diagnosis by maybe a few months or a year in someone who is already headed down that path anyway.
And does the risk keep going up over time?
No, and this is crucial. The increase appears soon after starting therapy and does not accumulate over time.
And the big question, does the benefit of avoiding a heart attack still outweigh that small accelerated risk of diabetes?
For almost all high-risk patients, yes, definitively. The cardiovascular benefit remains overwhelmingly positive. But this is the kind of specific confirmed information that requires a deep, honest conversation between a doctor and their patient about the overall risk-benefit profile.
So the scientific battle about efficacy is pretty much settled. But as soon as that dust cleared, a massive new dispute erupted. And this one is purely about money and access.
For decades, statins were the gold standard. But now we have these revolutionary new treatments that lower LDL cholesterol even more effectively, the most prominent being the PCSK9 inhibitors.
These drugs are a phenomenal breakthrough in lipid lowering. So how do they work differently from statins?
Okay, so statins, they slow down cholesterol production. PCSK9 inhibitors like evolocumab and alirocumab, they work on the surface of your liver cells where the LDL receptors are.
And the receptors are the cleanup crew.
They are the cleanup crew. They grab the bad guy boats, the LDL, from the blood and bring them into the liver for destruction. The PCSK9 protein normally binds to and destroys those receptors, which limits your body's ability to clean up LDL.
So the drug inhibits the inhibitor.
Precisely. These drugs block that destructive protein. By doing that, they preserve the LDL receptors, meaning the liver can dramatically increase its clearance of LDL from the bloodstream.
And the result?
An astonishing reduction of LDL cholesterol, often by nearly 50% on top of what statins can already achieve.
That is truly game-changing for very high-risk patients who can't get to their target LDL levels on statins alone. So if they're more effective, different side effect profile, where's the massive controversy?
The price tag.
Ah.
When these breakthrough drugs hit the market, the initial annual price was dramatically high. It ranged from $14,000 to $15,000 per patient per year.
And compare that to generic statins.
Which are about $48 a year. This price difference just forced an entirely new conversation about health economics.
Okay, so this is where we need to put on our financial analysis hats. When a drug costs this much, the health system has to ask, is the added benefit, which is real, is it worth that staggering cost?
And they use specific tools to measure that value. We have to look at this from two very different perspectives: the societal viewpoint and the private payer viewpoint.
Let's start with the health system, the societal value. They use a metric called the Quality Adjusted Life Year, or QALY.
A QAY is the gold standard metric. One QAY is one additional year of perfect health added to a patient's life. It accounts for both how long you live and the quality of your health during that time.
And the second tool is the Incremental Cost Effectiveness Ratio, or ICER. This is the calculation that answers the dollar question.
What is the cost to gain one additional QAY?
Right. And society generally operates with a willingness to pay threshold.
Yeah.
In the U.S., that's often set around, what, $100,000 per QALY gained?
That's about right. If a drug saves a life or significantly improves health quality for a cost below that threshold, the system generally considers it cost-effective.
So at $14,000 a year, how did the PCSK9 inhibitors fare against that $100,000 societal threshold?
They failed spectacularly. At the initial market price, the cost to gain one additional QAY was estimated at approximately $350,000.
3.5 times what society is generally willing to pay.
It's a massive misuse of healthcare resources, according to the standard economic model.
So this means that for the drug to be considered a good investment for the health of the nation, the price needed to drop radically. What price point would make it cost-effective based on that $100,000 societal threshold?
The model suggested the annual price would need to be reduced significantly, down to approximately $4,250. That's the price that aligns the drug's clinical value with the societal value of preventing heart disease.
Okay, now here's where it gets really interesting. Because the U.S. system is not a unified societal system. It's a fragmented private payer system.
Right.
And the insurance company's financial calculation is much, much stricter than society's.
This is the private payer dilemma. It all comes down to return on investment, or ROI. Society benefits from a heart attack that's prevented 10 or 20 years down the line, but insurance companies, they face the turnover hurdle.
Explain that hurdle. Why can't the private payer benefit from preventing a heart attack 10 years from now?
Because of patient mobility. You have to assume a standard 12% annual turnover rate, people changing jobs, moving, switching insurance plans.
So, the insurance company that paid $14,000 a year for the drug for 3 years
is likely not going to be the same company that avoids the $100,000 plus cost of a heart attack years later. They lose the benefit of the avoided cost.
That dramatically shifts their calculation. They can only justify that high price if the cost avoidance happens really quickly, or if the drug is just cheap.
Exactly. And when you model the private payer's financial reality, where they only capture avoided costs and premium revenue during that short window the patient is enrolled, the numbers turn terrifyingly negative.
So at the initial price of $14,000, what was the private payer's return on investment?
It was a disastrous outcome. For every single dollar the insurance company invested in PCSK9 inhibitors at that price, the analysis showed the pair actually lost $1.98.
Lost money on him.
The drug was, statistically speaking, destroying their profits. And this massive financial penalty explained why private payers put up so many barriers. Prior authorizations, high tiers, massive deductibles, they just couldn't afford to cover it.
This is a spectacular disconnect. For the average private insurer to achieve a positive ROI just to break even, what price did the analysis show was necessary?
The necessary price drop was staggering. For the average private insurer to break even, an ROI of 0, the annual price had to drop drastically to just $600.
$600. Think about that value gap. The societal model says this innovation is worth $4,250 a year to the nation.
But the financial model of the American insurance system says it can only afford $600.
That's a difference of over $3,600 per patient per year.
And this enormous difference, it just illustrates the key failure of the U.S. value-based payment system. A patient's access to life-saving innovation isn't determined by the drug's clinical efficacy, but by the financial reality of high patient turnover and the short-term profit motives of their insurer.
So access, not efficacy, became the new, immediate frontier of the statin controversy. Okay, we've established that efficacy is proven, solubility matters for side effects, and cost is prohibitive for the new drugs. But for that vast middle ground, the patient who is considered intermediate risk and is debating whether to start a lifelong statin, how do they navigate all this uncertainty?
This is where we shift to the powerful new tools that are aiding those patient-doctor discussions. And the most critical tool is the coronary artery calcium score, or CAC score.
Well, what exactly is a CAC score?
It's a quick, non-invasive CT scan. It can cost as low as $75 to $200 that measures the amount of calcium or plaque hardening in the heart arteries.
And since that plaque is caused by those sticky LDL deposits,
A higher score means you have established, measurable atherosclerotic disease. It literally shows you the damage those bad guy boats have already done.
which is so much more precise than just estimating risk based on age, cholesterol, and blood pressure. It grounds that abstract risk in the patient's own unique, measurable biology.
It's revolutionary because it's a direct measure of disease burden. The new guidelines from the American Heart Association and the American College of Cardiology, they now emphasize CAC scoring as a critical factor for intermediate risk and some borderline risk patients between 45 and 70.
And what's the most powerful outcome of this scan? It's what the experts call the power of zero.
Absolutely. A CAC score of 0 is highly predictive. For a patient who is considered intermediate risk but has a perfectly clean scan, a score of 0, their risk of a major cardiovascular event over the next 5 to 10 years is extremely low.
So in that group,
In this group, statin therapy may be safely withheld or delayed, even if their cholesterol numbers are a little bit elevated.
which gives the patient the choice to avoid a lifelong medication and the associated side effect risks, like that small diabetes risk we talked about.
Exactly. The key exceptions where a 0 score doesn't exempt you are those really potent risk factors, like active cigarette smoking, having diabetes, or a very strong family history of premature heart disease.
But for everyone else, zero means you can probably wait and monitor.
Correct.
And conversely, what if the scan shows a high score?
A high score signals immediate action. A CAC score of 100 or higher, or a score above the 75th percentile for their AIDS group, is generally considered a strong indication for statin therapy.
I can imagine that visual confirmation of hardening arteries is a powerful motivator for patients.
It is. It helps them adhere to treatment, and it can overcome some of that nocebo effect and the fear that's been generated by all these academic disputes.
Okay, let's shift back to the financial dilemma with the PCSK9 inhibitors. We identified that a $600 price point is needed for insurers to break even, but the societal value is way up at $4,250. How can we close that massive gap? How do we ensure patients get access?
There's a forward-thinking solution that's gaining traction. It's called risk sharing through outcome-based contracts.
A creative reimbursement strategy.
Right. It attempts to align the interests of the pharmaceutical company, the insurer, and the patient.
So how does that work in practice? It sounds like the price is determined after the drug is used.
It kind of is. The core concept is that the price and any subsequent discounts are tied directly to the drug's actual performance in the real world.
Give me an example.
Okay, so the insurance company enters into a contract with the drug manufacturer. If the patient group receiving the PCSK9 inhibitor doesn't achieve the expected reduction in LDL cholesterol, the reduction they saw in the clinical trials, then the manufacturer is penalized.
They have to offer large discounts or rebates.
Exactly. It's a fascinating way to transfer financial risk. The insurer is less concerned about that initial $14,000 price tag if they know the pharmaceutical company is guaranteeing the clinical outcome.
It puts the risk of the drug not performing back on the company that made it.
It does. If the drug is truly as valuable as they claim, they should be willing to stand behind its performance financially. And this mechanism may help these high-value, expensive drugs enter the market and ensure better patient access, bypassing that short-sighted turnover hurdle that paralyzes private payers.
A potential model for reconciling societal value with private payer reality.
It is.
What a multi-layered journey this has been. We started with a drug that is constantly in the crosshairs of controversy, but I think the most important summary is this. The historical skepticism has been largely settled.
It has.
The overwhelming scientific evidence confirms that lowering LDL cholesterol prevents major cardiovascular events. That argument, for all intents and purposes, is over.
Absolutely. The debate has definitively shifted away from efficacy. It is now focused squarely on two key areas. First, managing those small but specific side effect risks.
Where we learned that molecular solubility, fat-loving versus water-loving, matters a great deal for brain health.
And second, addressing the astronomical financial barrier to new, highly effective treatments like the PCSK9 inhibitors.
Right. The financial models revealed this chasm where the societal value of preventing heart disease, that $4,250 per QLI,
is just grossly mismatched with the financial needs of the private payer, who needs the price at $600 to break even.
And this financial disconnect is really the biggest problem facing the adoption of these new, highly effective cardiovascular treatments.
It is.
Which leads us to our final provocative thought for you to mull over. If the science is clear that LDL lowering works and innovation is providing ever more effective drugs, then the true controversy today isn't about whether these drugs are good.
It's about equitable access.
Given that massive financial gap between the drug's societal value, $4,250, and the private insurer's break-even point, $600, how can the healthcare system incentivize innovation while ensuring that a patient's ability to access life-saving treatment is based on their clinical need and not on the short-term financial model of their insurance plan?
The success or failure of things like outcome-based contracts will really tell us whether we can solve that fundamental challenge in the next decade.
Thanks for coming along on this deep dive with us. Remember to follow us on your favorite podcast platform, and see you on the next dive.